Well, I'll be honest with you. And this, I believe this in my heart. Right now in 2023, people are safer at home. I think that at least now, HSS and Mayo may be different. The rest of the world, and as you know, I'm doing a two-year stint non-compete in community-based hospitals, but I lived my life in academic centers. All of them are pretty similar right now in that with traveling nurses post-pandemic, there's been a societal shift. We're seeing more medical errors. We're seeing less accountability. We're seeing people wanting to be home in healthcare more than they are committed to their patients. So I will tell you right now, wholeheartedly, if it was my family member, go home.
Welcome to Coin Flips and Controversies, an OrthoBullets original series dedicated to exploring gray zone decisions in orthopedic surgery. This episode of Coin Flips and Controversies is sponsored by IOEN's Technology and Outpatient Hip and Knee Arthroplasty course, taking place May 11th through 13th, 2023 at the JW Marriott in Indianapolis. At this time, we will hand it over to the webinar faculty. We hope you enjoy the episode.
Hello, I'm Michael Meneghini from Indiana. I want to welcome you to the latest in Coin Flips and Controversies. Thanks to OrthoBullets for putting this webinar on a very pertinent topic, and also want to thank our sponsors, which is the International Orthopedic Education Network, and in particular a course that is coming up in about 6 to 7 weeks here in Indianapolis, Indiana, on two really important topics that we're going to focus in on the webinar, which is technology and outpatient in hip and knee arthroplasty. So two really, really important topics, very timely, very relevant, and hope that you will look at attending that course coming up here in a few weeks in Indianapolis. It happens to be during the month of May. There'll be some great events in terms of racing, and there's some great parallels that really exist between open wheel auto racing, the technology that industry has seen over the last few decades, and it really parallels the technology revolution we're seeing in hip and knee arthroplasty. So I think it'll be a lot of fun. And we have three spectacular faculty members with us tonight for this webinar. First is Nick Bedard from Mayo Clinic. Next is Beth Gausen from Hospital for Special Surgery in New York. And then one of my partners in crime here in Indiana, Leonard Buller. And you'll notice that these three faculty are younger than I am, and that's intentional. When you deal with technology and all the latest and greatest things, as will be consistent with this course, I have a feeling that the younger contemporary leaders in hip and knee replacement are probably better served to talk about these great topics than some of the older surgeons like myself. So we're excited to have a great course, great faculty, and I appreciate Lenny, Nick, and Beth for being here tonight. And thanks again to OrthoBullets for helping us put it on. So without further ado, I think we'll dive into this topic, and we've got a number of poll questions that have been out on OrthoBullets for a bit. We'll go through those and really walk through this case. So first of all, this is the case of a 76-year-old male, came in with left knee pain. This is not a complicated orthopedic issue. This is really around how we would approach this patient related to technology and outpatient. So comes in with severe knee pain, numerous cortisone injections, tried all the non-operative measures, and is ready for surgery. So let's look at the past medical history as we begin to think about whether this patient is a potential same-day discharge, number one. Number two, is a freestanding ambulatory surgery center a safe place for this patient? And if so, what are the requisites? And we'll start walking through these issues here. So you can see here, reasonably complex patient with some comorbidities. So he has coronary artery disease. That diagnosis was in 2006. This is a patient of mine that was just done recently. So this is basically real time. Has had a stent placed, and that was over a year prior to his surgery, and asymptomatic without using nitro. Okay, these are important sort of issues that we deal with when we're looking at patients and where they should be done, and able to climb a flight of stairs without any cardiac symptoms, shortness of breath, or what have you. Does have AFib with rate control. You can see he's diabetic, but type 2, but his hemoglobin A1C is 7.4. got a little bit of moderate aortic stenosis with left ventricular dysfunction with an ejection fraction of 45%, and then some past history of prostate cancer. Obviously, the physical examination is consistent with severe knee arthritis. And let's go to the x-rays, and then we're going to start our discussion. There's a lateral view of the left knee, and then if we go to the next, there we go, and there's an AP view. So clearly, I think end-stage arthritis. Now, if you don't mind, I want to get everybody's take on this. Lenny, what's your first glimpse at this? We'll dive into the poll questions here in a minute, but your first initial thoughts if a patient like this walks into your clinic, and you're deciding what to do with this patient. How do you start that process with the patient when they come in, all the talk of outpatient? Go ahead and walk us through that.
Yeah, I think that certainly the medical history is extremely relevant when we think about same-day discharge or overnight stays. When we look at his medical comorbidities, I think the key is that they're all controlled and they're all well managed, and we know about them. So this is not the typical patient that we generally get in orthopedics that has been followed up with a primary care physician routinely. This patient has everything really pretty tightened up. So there's not much more optimization that I think they can undergo. It's more a matter of risk assessment and perioperative management to try and optimize their care around the time of surgery to really keep them as healthy as possible. So I think that this is an ideal candidate for a knee replacement. They have end-stage arthritis. They're severely affected by that arthritis, although maybe not necessarily on stair climbing. It sounds like he's able to climb a flight of stairs. So, but other than that, this is, I think, an ideal candidate from a medical standpoint because he doesn't need any extra workup or any delays necessarily.
Yeah, no, that's a really great point you bring up, which is identified comorbidities that are optimized to the best they can be. And you're right, the symptoms the pathomedical history is cardiac symptoms, not knee symptoms.
Yeah, hopefully his knees hurting on the stairs.
Oh, good point. No, you bring up those are great points. Nick, at Mayo Clinic, look, you guys some of the best care in the world. How do you all approach this? You have a great multi-specialty, multidisciplinary care. How would you approach this patient in your orthopedic clinic at Mayo?
Yeah, absolutely. We do have a pretty centralized approach to managing these patients. It based upon their level of comorbidity. So all of our patients go through what we call preoperative evaluation clinic. But that's basically, honestly, it's a nurse triage from the anesthesia team to determine what pathway they go down. And so based upon their comorbidities, based upon the need for, further evaluation by a cardiac specialist or somebody from the pulmonary team, then they'll go through those pathways prior to surgery. I agree with Lenny and what you've said. In these patients, this guy here, I don't think he would flag into doing anything additional. Not everybody's going to get echoes and get all these things. We're going to get our standard lab, standard workup. He seems to be optimized from that standpoint. And so he will see our preoperative anesthesia clinic prior to surgery. But I don't think based on this past medical history would flag not every person's getting cardiac workup. Not every person's seeing endocrinology unless they need to optimize in some fashion. And so for him, if his A1C was, much higher than where it is now, or maybe if that coronary artery disease, he was symptomatic with that flight of stairs, then they're going down a different pathway, probably even prior to picking a surgical date for some of those endpoints.
Great point. So what would be at Mayo, what is the hemoglobin A1C that creates a flag? I mean, that's close, I assume, right? Is 8 your cutoff?
Yeah, I think every surgeon is a little different. If we're above 8, we're going to be going down an optimization pathway. Some people try to get a little tighter than that. I think looking at the patient, some patients are more fragile diabetics than others. So optimization levels are different. We don't want them to get hypoglycemic and have them come in at a 6.5 and have an issue with that as well. So I think we have to balance where the patients are at, but a flag above 8 would trigger some optimization here.
Oh, that's a great point. And the point you mentioned about how the perioperative care of someone who's a diabetic, not coming in hypoglycemic, letting them have clear liquids, not restricting so much, making sure this is not your last patient of the day and you tell them to NPO for so much time, right? All these modern techniques. And again, I want to dive into some of these because doing an outpatient surgery has to be taken in the context of the overall larger program. We're different in 2023 than we were, for example, when I was a fellow at Mayo Clinic 17 years ago. The world is different, right? So we understand these. Beth, in New York, it's interesting. When we were going through the phase probably 7-8 years ago of everybody wanting to go to rehab, right? New York and the northeast part of the country was like the last ones. Everybody almost culturally demanded they go to rehab, right? That was a thing. And we knew it. And we used to hear, oh, they have a flight of stairs at home, they don't have social, et cetera. How are things in New York in terms of same-day discharge, outpatient, and how is HSS approaching this type of patient currently?
Yeah, so HSS, I mean, I think we're similar to Mayo, our setup, in that everybody goes to an HSS hospitalist that does the pre-op medical clearance or stratification. But this patient would probably get sent to, back to their cardiologist just to have maybe updated echo, I could imagine in this setting. That's probably the only thing I think that they would probably want. Just if we're in 2023 and the echo is more than a year old, they may want a new echo. But I would leave that up to the hospitalist. And you're absolutely right. I'm glad you brought that up, is that there are these regional cultural differences. And I would say the cultural norm in New York City is definitely, I'm going to have my surgery, I'm going to spend the night, and I may even go to rehab, more so than it was when I was a fellow at Mayo 3 years ago. And I think that's one of the big things that I'd like to learn from you guys that are doing a lot more outpatient joints, is just how do you flip the culture of that. I did a uni today, and the patient was 83, but really no medical comorbidities. And I fielded an email from their case manager last week that was like, her plan is to go to rehab. I'm like, that's not my plan. That is not my plan. But it is a bit of education, and really it's not going to be just 1-2 surgeons. It's going to be a cultural shift.
You're exactly right. It is going to be a cultural shift. And I think we'll probably get into that. I can tell you, from a statistical perspective right now, and we are a tertiary facility. We don't say no to anybody. We get referrals from across the region, across the state, infections, revisions, the whole 9 yards. And we see the really sick patients. Right now, just over 60% of our patients are performed in an ambulatory surgery center, and about 75% of patients are done same-day discharge. I did a revision today. It's the most complicated knee revision I've done. I did a knee revision today with cones, augments everywhere. Had to really build for a loose tibia that had been in for 15 years. And they went home same day. I mean, it was just because the surgical procedure was a bit more complex. The patient medically was not. And so I want to dive into this here in a little bit, but the anesthesia, the perioperative pain control, the preoperative optimization, all the things, Nick, you alluded to it, and Mayo was really sort of the people who started this, which was not making people NPO for so long before surgery so they don't come in hypotensive. We emphasize something like we emphasize euvolemia, because we've learned with, urinary retention, that can be an issue. So both either too much fluid or not enough fluid. So euvolemia is probably perfect. So we're going to get into some of these in greater detail. That's great conversations. You all talked about medically optimizing those patients. And I'm going to push you a little bit harder now, because some would argue we shouldn't be doing elective surgery on anybody who's not optimized. So now let's assume they're optimized. Now we're going to talk about specifically technology on these patients, and then same day surgery. So let's go ahead, Nick. Were you going to say something or not?
No, I was just nodding with you, because I agree that optimization should not, in my opinion, be any different for outpatient or inpatient. Yep. So you should.
And that's where you're hearing some people at the podium, quite frankly, and I'm not one of them, who say, well, if they're safe enough to have surgery, they're safe enough to be done same day, and they go to an ASC. I don't feel that way. I have a feeling those practices are not like ours. I think we're about as good as we can get at 75% at a tertiary. That's what my own belief. We'll see. I mean, maybe I'll be proven wrong, but so we'll get back to the outpatient logistics here in a minute. But the first thing I want to talk about is in total knee arthroplasty, because again, that's the topic of this course and topic of that's relevant right now. It's coming like crazy. What technology would you use for your routine primary needs? And I'm going to ask you 2 questions. This is not part of the poll, to focus the poll. One, you're going to use one in your hospital. If you have an ASC, do you use the same technology in your ASC? We can get into that in a minute. All right. So first, Lenny, what would you, of this that's listed here, I would not choose To do a total knee, that's inappropriate. We're not letting you do that one. I wouldn't use any technology, manual instrumentation, navigation, robotic assisted PSI. I'd use some sensors to get a great balance, or any combination of the above. Tell me how you would approach, what would your answer to be and how you approach it?
Yeah, so I do computer navigation on all my primary knees. Every knee that I do has a computer assisted navigation.
Why do you do that? Tell us your rationale.
There's a couple of reasons. So computer navigation, specifically of the femoral component, it's not going to only improve accuracy and precision to find a hip center of rotation for implant positioning, but it also supports reduction in blood loss, especially when compared to conventional intramedullary guides. And so when we're thinking about same-day discharge, especially in this patient with a cardiac history who's got demand ischemia potentially if he's losing his blood, you want to try and reduce that as low as possible. So if you don't have to put a rod up his canal and lose extra blood, why would you? And so I think that that's also beneficial, but that's really the trend. You know, the polls, we'll kind of see what the answers are, but the AJRR in 2022 has just shown computer navigation specifically, or some enhancing technology, has increased every year. And now it's up to 12% of knees.
Yeah, it's interesting, Lenny. You're exact. I could not agree more with you that it's really the euvolemic. We don't transfuse anymore because of TXA, but ironically, not putting a hole in the femur saves a gram of hemoglobin. That's the exact same amount that all studies have shown TXA does. So we're not doing it for transfusion risk anymore, because we're not doing that in these. We're doing it to maintain that euvolemia, and I could not agree. A very eloquently stated reason. I agree with you completely. Nick, what is your thought on technology and knee replacement in general?
So if I'm doing this surgery tomorrow, I'd be doing robotic assisted surgery on this. I'll be fully transparent. I am still not 100% convinced in the robotic surgery, but I have been utilizing it more recently because I've liked what I've been able to achieve with it. So I think that when I say I'm not 100% convinced, is I do want to see the long-term outcomes and the patient data difference. But in my hands, what I've liked about it is I feel like I can more easily achieve the goals that I like to do with less surgery. So the amount of
what are those goals?
So those goals in my mind are a well-balanced, well-aligned knee with as minimal as soft tissue releases as I need to do. And so I'm okay doing bigger releases and balancing a knee even in robotics, but I do think there is some morbidity with that. There is some pain associated with that and additional surgery. So what I've been happy with is with robotics is hitting my target and sort of achieving that balance, I think, more efficiently and effectively in my hands with robotics. Whether that pretends to improved PROs and differences in revision rates, I will be fully honest that I don't think we have that data yet, and we may never. But I do think that some of the blood loss, some of the staying out of the canal definitely play a role as well. But I just like being able to hit my target more consistently. And I honestly think I can do that better with robotics.
And it's not the topic of this webinar, but this topic is going to be covered at the course in detail because it's hot. Are you doing? Tell us your target real quick. Are you doing personalized alignment? Are you doing kinematic? Are you doing traditional mechanical alignment? What's your target in terms of alignment only?
Yeah, that's great. So I wouldn't throw another one out there, but I would lump mine under kind of bounded kinematic. So what I'm doing is I'm using
personalized, I would say.
But I'm not doing, insane amount of varus or valgus. It's just sort of within what I think is acceptable and allowing a little change in rotation, a little change in varus, valgus, cuts, slope, or whatever to achieve that balance and minimize the need for ligamentous releases.
Great. That's a whole webinar in and of itself, obviously, right? But great. So Beth, tell us how you're going to approach. Now, there's a ton of technology at HSS. I think there might be more robots at HSS than their entire state of Indiana. So tell us how you're going to approach this.
Yeah, and I'm with Nick. I'm still not totally convinced that our tools are fine enough yet to determine if there's a difference between a robotically performed knee and a manual knee. So the majority of my practice thus far, the past 3 years, has been I sound like an old surgeon because it's been cemented manual knees. I use navigation on the tibia. I don't use it on the femur. And I hear your point, Lenny, for sure, but I've transitioned. Actually, the Vail meeting kind of made me a believer. Hearing you and some other people talk, I felt like I was this like young surgeon who was not adopting technology. So I went back and I started dabbling in the past 6 months or so with multiple different robots, because we do have that luxury at HSS. We have multiple. I really do prefer at this point, if I'm going to use robotics, which I am gradually transitioning towards, I like CT based robotics. I think it does end up saving me a little bit of time. And I think we'll get into this too, because I'm about to open a can of worms. But I think if you're going cementless, you really can get, a couple advantages. One, your cuts are probably a little bit more precise, particularly on the femur. And two, I think it actually, if you're going cementless using the robot, you can become closer and closer to time neutral. So I think there are some advantages there, and I've really liked it. I agree with Nick, is that I'm doing less soft tissue releases. It's making me more precise. I don't know if that's going to translate to improved early outcomes or improved late outcomes, but I like doing it right now.
No, I think you bring up great points, Beth. I really do. Go ahead, Larry.
Yeah, let's talk about the ASC a little bit. Are the robots in the ASC too? And space constraints, cost constraints, are you guys doing those in the ASC as well?
That's a great question, Lenny. So I, full transparency, I don't have a freestanding ASC that I work at. So if my patient goes home the same day, or I'm doing one of the biggest revisions I've ever done, it's in the same operating room for me in the same building, and pathways afterwards. So I do have that luxury of not having to make that decision. I think that's an important thing to think of, because you have to balance, I think, what you can do in your hands, and you have to look at the robots or the navigation or any of the sensors. These are just tools. And if you can achieve the outcome you want efficiently and effectively and safely for your patient, then you can figure out where those tools come into play. And the cost of obtaining those tools is a factor you need to consider. And so freestanding ASC, how you bill, how you reimburse, how your hospital makes money off the surgery they do. I think those are important factors that are going to weigh into those decisions of whether or not to use them until one becomes a clear leader. So if there's a technology you say, this is the way to do it now, which I'm not sure we'll ever get there, then you start saying, well, am I doing the standard of care? But right now, these aren't. I would say a manual knee is still standard of care. And so you can treat your patients how you think is best, but you do have to consider cost.
Yeah, and I think that's a great point. Lenny, obviously you've been in the healthcare policy world for ACUS. That's a really important thing. And no matter what healthcare system we're in, as conscientious and ethical orthopedic surgeons and physicians, the world has changed. We have to understand the value equation a little bit and make sure that the technology we use is not overly priced. I think that a lot of times we get in the discussion of the ASC and it's about the margins and the physicians own them and whatnot. I just think really it's about cost to the healthcare system, and is it value driven? I think we're in that period right now where we're determining the value of this of robotics and this technology. So I'm not against it. I do think you have to decide where it applies. I'll give you a real world example. Is that usually the Medicare margin in ASC on a total knee replacement is $2,000 to $3,000. When I say margin, that's the profit once you do all your implant costs, your costs for the nurses and everybody who's caring for the patient and turn on the lights. It's usually about $2,000 or $3,000. So, the disposables of technology come into play, whether it's a robot or per case, like, one of the handheld accelerometer based, they're all going to cost $750 to $1,000 per case, and then plus capital. So, I think we have to keep studying it, right? To all of your points, does it improve patient care? Does it improve outcomes? If you can do a better knee and you better serve for your patients, then that has a value to it. So, stay tuned. So let's see what the polling showed. And Beth, you're not that far. You're not out there that far. 64% we're not using technology yet. Now, what I don't know is the ortho bullets, people that are on ortho bullets, is there a selection bias there too, right? If you were to take ACUS as a whole, or you take all Academy as a whole, and then 8% said yes to navigation, 13% robotics, that totals about 21% of sort of mechanically, alignment technology, if you will, which is pretty consistent with some of the AJRR data we're seeing now. And then PSI is 6%. Interesting that sensors have fallen off.
Yeah.
Probably because the people who are sensor driven are probably gonna be in that 13% of robotic, I would gather. And even some of us who do navigation, we're paying attention to it, but not in overt quantitative way like we did with sensors. What do your gut, Lenny, what's your thoughts on this polling?
Yeah, I think, like you said, it's very consistent with what the AJR suggests. So I think that this is probably an accurate representation of American practice currently. There might be a slight bias towards the younger surgeon on ortho bullets, I would bet.
Yeah,
so maybe
I
it's
agree.
just a little bit higher than what average would be. But yeah, I'm not surprised at all that the majority of knees are still done with, especially a straightforward varus knee. I think a lot of folks think it's just fine to do this as a mechanical, a conventional instrument knee, do a little soft tissue release and they're good to go. But to Nick's point, I think that's where exploring some of these individualized alignment techniques with enhancing technology and theoretically some less soft tissue dissection and maybe less swelling, maybe less pain, can get people accelerated in their recovery and get them out of the hospital or out of the ASC with less calls and less pain. I think that there's something maybe that will come out of that.
Beth, you were gonna say something?
Yeah, I was just gonna say, I thought, and I could be wrong, but I thought there was an ACUS polling question too this year that was, any of your knees are robotic? Like, what are you a surgeon that use any robotics in your total knees? And it was like 50%.
It was.
So I
That's
think
right.
even though these numbers look relatively low, I think
Yeah.
there's a lot of people like me that every month the percentage goes up and up,
Yeah. Yeah, and I think it's gonna be very interesting. Well, let's go quickly to the article that I picked. It was interesting because with every new technology comes, and my job as a moderator, I believe, is to provide balance. And with all emerging technology comes some issues. It's interesting that when we first started doing robotics, there were some issues, and this was with navigation too, when they were outside the incision kind of pens, and some of them still are. There were actually fractures. They were doing knees and there were femoral fractures. I know that from multiple studies. So this was a really just Leonard did a nice job in his team. That's like saying, okay, what are the pin related complications? And the good news is most of them are mild and they relate to, either some superficial cellulitis, and all, none of them were disastrous outside of that disastrous complication of a femoral fracture. I think as we expand and we start to go into ASCs, the only reason I bring this up is an ASC may not be the best place to deal with a spiral femur fracture. So I would say that as we bring technology into the ASC, we got to be careful about what kind that is, and just these rare events, just be prepared for them. Rare events can happen no matter what, but I just showed that for balance. Beth, any thoughts around that at all? You do a lot of trauma, so I mean, have you seen any complications related to pins at your institution? You have so many robotics. Have you seen any of that?
I know there's been fractures, but I haven't taken care of any. None of my own. I have seen patients, if I tend to put my pins outside of the incision still. Again, I feel like I'm an old person here, but the biggest complaint that I would get, which is still a very small minority, is, oh, this pin site actually is more painful than the rest of the incision, and people get bothered by that. And it's kind of like a visual thing.
Yeah.
So I think probably the move towards putting them intra-incisional does make sense. One thing I heard, actually discussed it with a partner today, and I'm curious if you guys have thoughts with unis. If you're going to do a robotic uni, worrying about putting the pins actually intra-incisional, that it could be close enough that it could create a stress riser that could then create a fracture near your uni. So there's no free lunch. Anything can cause a complication.
Yeah, I think it's choices and compromises. And if you're going to introduce technology with pins, these are some of the compromises, and you have to balance whether or not you think it improves your outcomes. Now, all my pins are interlesional. I don't have any great data on this, but I actually think that fracture risk, maybe with the uni, as you suggest, is different, but having them in closer to the metaphysis, into the supported bone, in the area I cement a lot of my knees, into the area where the cement's going to be infiltrating that, I think that's somewhat of a protective effect. I put them interlesional for the unis as well. And you don't have to hit that hard to get a uni down. So I think from a fracture standpoint, it should be okay, but that is a thing to think about.
I agree. I think as we bring them closer to the metaphysis and the epiphysis, I think it's better. I do agree. So I think it's just technology advancing, right? Learning from the past, learning from the issues. All right, let's go on to the next polling question.
To your point, just briefly on the ASC, right? Enhancing technology in the ASC. I think that if you have a complication and you're not at the steady state, you're still in the learning curve, there's something to be said about that. You should be, when you're trying to bring a patient to the ASC, you're not going to be dabbling with new technology. You
Great
should
point.
know how to do this efficiently, and just like any surgery, you have to be tightened up. Your team has to know exactly what's going on. This isn't something to just practice around. So practice in the hospital, not in the ASC, I think.
Yeah.
No, I think
Just
that's
like, well, let's try this today. Yeah. I agree.
Yeah, exactly. Not so much.
Go ahead. Yeah, you're great point. Well, and it's not even just about something catastrophic like a femur fracture. It's something so simple as, and you mentioned this, Lenny, surgical time. So remember, you know, when you're in an ASC, the PACU is not used to, you know, heavy revision, heavy joint replacement patients coming out. Or the longer the surgery time, the more the fluid shifts are, the more pain they're in, the more, and they're just not used to that or equipped to that. They need consistent. So I think it's a valid point. If it were done in an ASC, be thoughtful about the introduction of technology. I think it's a great point. All right, poll question number 2 for total knee replacement and same day surgery. Let's go back to what we were talking about, how you would evaluate the patient. We all know that you have programs, people that you send to make sure they're optimized. Now we're going to take it another step further. If you're going to discharge this patient home same day, do you do anything different? Nick, what do you do at Mayo? Do you have a same day discharge? I know you guys are doing that now, even though you have an ASC. Is there something different that you do when you know a patient's going to go home the same day in terms of evaluating and qualifying them? How do you determine that patient?
From a preoperative standpoint, that doesn't change for us. I mean, in terms of qualifying them for the outpatient setting, I guess it does change a little bit. Sorry. From optimization doesn't change. Qualifying
Right.
them, you make that decision in the office with the surgeon and the patient, and then that pathway gets started. So we don't have somebody that says yes or no if this is appropriate for outpatient. Probably because they're not going to a standalone building. Some places have hard stops on different ASCs based on comorbidities and things, but we're operating in the same building. I think that one of the biggest things that make that decision is their social support and their family members and buy-in that they're going to be going home that same day. You know, making sure that's squared away when we indicate them. That is something that happens though between me and the patient and who's ever sitting there in that room that day when we decide about discharge planning at the time of indication. So you have plenty of time for them to prepare and get resources set up to leave that same day.
Okay, great point. So medically optimized. Now you're looking at social things. Beth, let's talk about New York and how that's evolving. Now I know you guys are starting to get into some ASCs at HSS, and
Yeah,
Mike
and
asked
we
us
do
thoughtfully.
discharge same day from the the main hospital as well. There's some of us like Mike asked, who's coming to the course. He's definitely a leader in that, and I think he probably is sending over 50% of his patients home. Not quite as many as you, but it's still a pretty good amount.
Yeah.
I am you know, my revision percentage is still high. My office and my flow is not exactly set up to optimize people yet to go home. I talk to everybody about it and I give them the option. I would say, and this is another thing I want to learn from you guys that are doing more of it. I'm typically leave it, you know, I leave it very open-ended to the patient. You have the option. We could do it earlier in the day. You could go home that day, sleep in your own bed. If you feel more comfortable spending the night, you could spend the night too. And the majority
As soon as you say that second part, they
right,
ain't going
it's
anywhere.
done. It's done.
It's over.
So how do you say it? How do you say it?
Well, I'll be honest with you. And this, I believe this in my heart. Right now in 2023, people are safer at home. I think that at least now HSS and Mayo may be different. The rest of the world, and I'm, as you know, I'm doing a two-year stint non-compete in community-based hospitals, but I lived my life in academic centers. All of them are pretty similar right now in that with traveling nurses post-pandemic, there's been a societal shift. We're seeing more medical errors. We're seeing less accountability. We're seeing people wanting to be home in healthcare more than they are committed to their patients. So I will tell you right now, wholeheartedly, if it was my family member, go home, get home safely. Do not, the longer you're in the hospital, the longer somebody's going to do something bad to you. And I hate to say that, But if it were me or my family, that's the way I believe that. And so I tell the patients, if you need to stay in the hospital for medical reasons or because you're unsafe, we will keep you there. But otherwise, the safest place for you, and I tell them, if you were my brother, sister, father, mother, I would want you at home. And then we still have a couple people that say, well, you know, can I go to rehab? We just got I heard my nurse talking to somebody today that called, they are having a uni and they want to get, she did the same thing. They have a uni, they want to go to rehab. I tell them absolutely not. And they're like, she's like, I go, first of all, you tell them what I always tell every patient. I wouldn't send my dog to rehab. Okay. First of all, number two, I mean, a vet's better than rehab, right? The data is very clear on that. And then number two, if you need to do what's right and you start to tell them about what happens in hospitals these days, someday the data is going to come to light on what our hospitals look like post-pandemic compared to pre-pandemic. I don't know that it's much better.
What about this one? What about the patient that had their knee or their hip done 5-10 years ago that spent 2 or 3 nights and they say it was really comfortable, I had a great experience, I just want to stay again? Because I do get a lot of that too. What is your answer?
Sure you do. I tell them the exact same thing. The world has changed. I use COVID as a great excuse. And I basically tell them that post-COVID, the world has changed. You should be home. You'll have the same great experience at home. Now, the one you can't get over, the one you cannot get over, because none of us are marriage counselors, is when their spouse wants a break. And I literally literally say that to them. And, you know, the 3 of you are younger. When you get older like me, you won't care anymore as much. And I will say, I'm not a marriage counselor. And they look at me and I'm like, I'm not getting into this. I'm not, the fact that you need a break from your spouse. And then I usually tell them, because I'm a Medicare, I'm a taxpayer, I said this to a patient once, I think my nurse probably didn't like it, but I said, are you on Medicare? And they're like, yeah. And I said, I pay taxes, right? And they're like, yeah. I'm like, so you're asking me to pay for you to stay in the hospital when you don't really need it? And you should have seen they actually started laughing. And then I was like, but I'm not really laughing. Anyway, so it's just an extra cost. But look, Beth, in all fairness, you're never going to get over some of those humps. And I won't either, no matter how, angsty I get. But
I think you're right. I think that it really does. I think it starts from the surgeon, the way the surgeon talks about it.
It does. And it's education.
Yeah.
It has to be the plan from the beginning. Or right. I decide an indication. We also see patients preoperatively, like I'll see them the day before surgery. But if you're making decisions, then there's too much emotions. There's too many logistics. Patients aren't ready. They're nervous about surgery. And so to me, they get signed up. Some people are a few months out. It's day 0 when I indicate for surgery, hey, let's figure out our discharge plan. Even if there's medical stuff in we know if we're going to try to go home the same day or not. And so discharge plan then, and then it's constant messaging therefore all the way out.
Well, messaging is key, right? The messaging. How do you
present it, Nick? Like originally, do you say like, if somebody, let's say it's somebody very much a candidate for not even a question, very much a candidate. Do you say like Meningini, you say I think it's safest to go home? Is that your approach too?
Yeah, I mean, part of my spiel, I'm not going to give it to you, but my little spiel I give to my primary hip.
Is it proprietary, Nick, or what?
Secret sauce.
It'll be finalized here in a couple of weeks from a point. No, but what I do say is just, I tell them if somebody that I think that very clearly can go home, it's not really an option. Sort of like when they're asking about surgery, I say, hey, here's what we do. Here's the risk and benefits. You'll be up walking the same day. You'll be able to discharge to a hospital, or if I'll know where they live, I'll peek where they live. You can get back to Casson today. It'll, an hour and a half drive after you get out of the hospital, and then you're on your way. And it's just sort of, that's the messaging. And if there's pushback, then we address those things. Now, if you're on the fence, or if it's this, maybe I know age is not a risk factor, but somebody that you're worried about their social support or ability to discharge, or they live alone, then I'll just have an open discussion and say, this is my preference. This is why I would prefer it for you. And this is why I think it's important to align somebody that's going to be able to help you after surgery, at least for a couple of days. You don't need 24-hour assistance, but you will want somebody checking in. You will want somebody there, driving you from the hospital. And then we figure that out for those people that you can just tell probably don't off the cuff have that social support right away established.
Mm-hmm.
That's a great point. Lenny, tell us about the education piece. Nick mentioned something really important, which is the messaging, right?
I was just going to say the value of having the team all reiterating the same thing. Everybody's got to be on the same page. So I think that if, like, when they walk in the hospital, if the expectation is set, they're going home the same day, and the therapist that speaks with them, the nurse that speaks with them, the anesthesiologist all says the same things. You're going to check these boxes and then you'll be home safely that night, resting comfortably in your own bed. Dr. Buller is going to send you a text the next morning, or he'll give you a call the next morning to check on you. Those are all the things they want to hear to feel safe. And Beth, to the point of like, well, what are you saying to them specifically? I think if they give a little feedback and say, yeah, well, my line is, the hospital is a place for sick people, and you're not one of them. You just had a surgery. Wouldn't it get you out of the hospital as quickly as possible? And that resonates with them now since COVID, I think.
Yeah, you're not coming in for pneumonia. You're coming in for a
Exactly.
joint replacement. You're otherwise healthy. Like you're
Yeah,
not.
but on the same token, you're not going to leave the hospital if you're not safe. So we have some appropriateness criteria that you have to meet after surgery, that if you don't meet those criteria, then we have to have a backup. And so that's where the decision between ASC versus the inpatient setting, whether it's either way, same day discharge, that's where I'm leaning a little bit more. If it's a questionable one, they want to go home same day, but I think, yeah, they might have failure to launch, or it's a later in the day case. That's where an inpatient hospital same day discharge is, or like a hospital same day discharge is probably a little bit safer, because you just have an easier fallback. But I agree, to Nick's point, I think that regardless of what we're doing to medically optimize them, the social support network is the most important. So having a coach at the preoperative joint class, having a coach at your pre-op appointments, they have to have that support person there to understand that that's the expectation too. And then the question is, well, what are we doing for them overnight anyways, right? Like, we looked at over 1,700 of our patients that were eligible for same day discharge, and we said, what are they doing that night? They're just sitting there. 84% of them didn't get anything done. They just sat in the hospital overnight doing nothing, getting a nosocomial something, or getting, a bed sore. In reality, there was not much that needed to be done. So it's a lot easier to just do it at home anyways. They're not having any knee pain because of our blocks and our perioperative protocols we're going to talk about. So it's just safer to be home.
Yeah, and Lenny, you bring up a good point. That paper we published was looking at everybody who went the next day, because we thought, okay, keeping them overnight would be some magical thing. Because everybody says, well, just keep them overnight. We did like 13 tests or whatever. The majority of people were in and out. The only intervention they had was an INO cath for urinary retention, which would have resolved if they'd have been home anyway, and they wouldn't have got that stuck in their urethra, right? And then they was like 4 EKGs, all were negative. Like there was like we didn't do anything for any of these people. They just sat there and consumed resources at Hotel IU Saxony, which was our hospital. And so your point's valid, but I'll tell you about the messaging real quick. We'll get on to the paper that I chose just to discuss briefly with this. Is the messaging is not even, we're at next level now. So I'm even thinking about, instead of a joint class, doing individual teaching sessions, because if you're in a joint class and you're a same day discharge, that I've told you that, and you're sitting next to someone who thinks that's crazy, or someone or that we've allowed to stay because they have poor homework, and they're like, I'm going home same day. And they talk to the next patient, they're like, what? I'm staying overnight. Now you've created a whole nother, it's not just the therapists, the nurses, even the other patients or neighbors. How many of you talked to them? My neighbor said they stayed 3 days in the hospital. I'm like, anyway, so that's let's go on to the article, but the messaging is key in your entire program, and setting patient expectations. So the polling here it's interesting, and I think this is reasonable, by the way. I do not think this is wrong at all. I think this is good. 46% of patients would not, or of surgeons would not do that patient as same day discharge. I think it's totally appropriate. Oh, it looks like the surgeon would clear them in 11%, or determine that medical doctor or primary care doctor in 16%, and the combination of, yeah, that makes sense. So that's reasonable. Let's see the article real quick, move on to the next poll question. So this is an article I picked that was really interesting, because this was one of the first articles. This is out of Kaiser Permanente, large numbers. And interestingly about that health system, and I knew this for years, they did a surprising number of outpatient hip and knee replacements. They were very progressive, and they're very programmatic about it. And what I can't figure, I mean, this was an amazing study, because it's all patients. It has its flaws like any study, but it was looking at all those ASA classification of 3 or greater, and 3 is sick. I mean, that's like, now granted, some of the ASA 3s, as we've shown with our specific score that we use, are not sick. So if you get like this patient would be a 3 because he has a stent and he has cardiac disease. We in our scoring system would say he's okay to be done as an outpatient. That's why the ASA is not so predictive, because everything's optimized. ASA does not check whether things are optimized. That's the downside, but pretty good indication. They didn't see any increase in readmissions or complications in same-day discharge in a really overall sick medical cohort. So it was an interesting paper. So one of the beginning signs that this migration of hip and knee replacements into the outpatient space is feasible, even at sicker, even patients with greater medical comorbidities. Any thoughts from the 3 of you?
You know, as you start thinking about selection criteria and medical optimization, obviously your proprietary ORA score, or outpatient risk assessment score, is one option. ASA has probably been shown not to necessarily predict safety of same-day discharge. What are you guys using alternatively? One paper I read recently from joint implant surgeons was pretty pragmatic. It was basically, do they have a failing organ system? Yes or no? And if they don't, are they having an appropriate social system? Do you think that's enough now?
Yeah, I've heard them talk about that for a long time, right? So yeah, it's so simplistic. I understand it. It resonates, right? The terminology failing system probably is not the best. We talk about medical optimization. Some could argue, and this may, Keith Barron's a good friend and he's very progressive. Just at the last CCDR meeting, he hasn't been at the hospital for over a year. He sends anyone who wants to stay at a hospital, he sends to his other partners, and he won't do anything that's not same day discharge anymore. But I think it goes back to the point we discussed earlier, that if your medical systems aren't optimized and you have an end organ failure, should you even have hip or knee replacement? That's why I don't know that sort of that bit of a crude thing. The other thing we've talked about is things like the RAP score. So because one thing that is sort of embedded in our score, but not overall dominant, is patient mobility. How can they get up? Now, people talk about that. Oh, they're not walking great. Well, if you're doing surgery on end-stage arthritis, they shouldn't be walking great to begin with. So you just have to get them back to their baseline. Like, you shouldn't also have faulty expectation that they're going to walk out of the hospital like they just got, like you're the miracle worker, because that doesn't happen. They limp coming in, they're going to limp going out. So that's just something we got to wrestle with. But anyway, this is from a medical perspective, but you bring up great points. Let's move on to the next poll question. Trying to be cognizant of time here, because again, that's why you need to come to the full course. We can talk for days about this topic. It's so evolving. All right, Jew same day outpatient at the ASC, what safety net would you implement? And I think this is important because even though, Nick, you guys don't have a true freestanding ASC, Dr. Buller does, and Dr. Galston is getting them. They're forming. So the question is, as you roll out these programs, and I'm sure Mayo will at some point, what is the safety net that you consider? What are your, Beth, tell me about what you think of as a safety net. Now, I already know doing them in the hospital is one. What if you were to take them to an ASC? What would you want to feel safe for you?
And our specific situation is those ASCs are not going to be, well, at least where the joint replacement will be, are going to be a little bit distant from the main Manhattan campus. So I think what's happening is they're establishing relationships with local hospitals as a safety net. And I think that probably makes the most sense. If you run into a complication that really should be hospitalized, you don't want to transport somebody 2 hours to get to that hospital or get stuck in traffic. So I think having a local relationship, that's what we're doing. I'm curious to hear what you guys have set up.
Nick, what are your thoughts?
Yeah, obviously, I think not having a plan is not an option. You need to have a plan how you're going to care for your patients and where you're at. Now, it's a rare thing, but I think having some sort of, whether it's a hospital across the street that you work at, or like Beth said, a local connection. But I do think that, planning on a skilled nursing facility, rehab facility, in my mind, if you're going to have one place, it should be the ones that can manage the femur fracture, but then can also admit them and do the therapy and get them around for the failure launch. I think you have too many pathways for your safety net. It just gets confusing, and you're only using them very rarely, hopefully. And so that becomes, one place a year, twice a year, if they're spread out, that you don't have that consistent messaging and communication on their end and where they go and how it happens. So to me, I would pick a hospital, and I would just have it be established with them to get any type of failure to launch there, regardless of the complication.
Yeah, great idea. We actually had a case this morning, my first case this morning, 7 a.m. routine primary knee. Woke up with pelvic pain and pain in her buttock and her proximal thigh. It's a very rare complication of epiphane spinals. And all of the spinals actually can cause it, but it's rare. Her knee was fine, no motor loss, urinated, no urinary retention, nothing, just pure pain in the pelvic region. She felt it was full, what have you. She stayed longer than everybody else today. We watched her through it. I got a call from one of the non-program anesthesiologists who was circulating. We need to transfer the patient to the hospital. And I was like, why? Well, to get a CT scan to find out why she's having so much pain. I immediately called my hip and knee replacement anesthesiologist, the CRNA who did the case, got everybody together. We talked to the patient, the family, everything's good. She's actually a nurse. So that just shows you one example of, do we need to transfer to a hospital? So I agree, Nick, your point is you got to have it worked out ahead of time. And we knew if we needed to, where we would send her. We knew it's right across the street, but you got to have that worked out ahead of time. Lenny, any additional thoughts before we go to the poll?
Yeah, I think a couple of things. I think the question about if they're not safe to go home, what are you going to do? I think it depends on the reason they're not safe. I'd make sure that you got to have staff that's available to stay late and overnight. Because if a PACU nurse can manage it, that's a lot easier. But I don't think that a surgeon should enter an agreement with an ASC if you don't have a clear emergency plan, transfer agreement with a hospital that you have privileges at. So I've taken care of a couple of patients at our freestanding ASC from surgeons around town that work there that break a femur. I just did one 2 weeks ago. Distal femur periprosthetic, totally dusted on a cementless knee, and the surgeon conveniently didn't have any privileges at the hospital. So I ended up taking care of that at night, cleaning it up. He gave me a call, said, hey man, I don't have any privileges. Can you take care of this? Well, that's abandonment potentially of the patient. So you got to know where you're at, and you got to have privileges, and not every hospital that's right next door is going to necessarily give you privileges. So I would make sure you have that first.
That happened in the ASC.
Yeah.
Now, what about your guys' ASCs? Do you have enough, let's say, do you have like a just in case cart where you have a, the femoral plate you would need and a couple screws, and you could revise that?
Yeah, it's a staged preparation setup, if you will. So the stuff that occurs more frequently, like like we have for knees, we have a varus valgus constrained poly and a PS in case you get a ligament, especially, we have learners, we're, fellows and residents. So we got to have all that stuff. And even if we didn't, it'd be good to have that. For primary hips, I have a 2-pan or 2-tray revision fluted modular stem in case I happen to crack one past the lesser trochanter, and we always have cables that live in the ambulatory surgery center. So that's sort of the upfront cost that we definitely have. Ironically, I would say make sure your ASC is outfitted with those capital purchases before you go to advanced technology like that. And those take some cost. Then there's those things you just talked about, Beth, which is plates, more catastrophic things. That is really determined, in my opinion, by how close your ASC is to a facility that has all that. If you're across the street, they can run and get it. That, that's just one.
Okay.
Like that case today, I looked at my rep and I'm like, hey, do we have the femoral cones here? Because there's a chance we get that femur off I need. He goes, no, they're across the street. And he goes, I'll go run and get them. And they were already sterile. He ran over and got them. He had them. That's a place you can do revisions versus I'm 20 miles away. And so this is where you're spot on in terms of when we're going into ASCs. And we're the ones responsible, by the way. The anesthesiologists aren't, the reps aren't. This is, you, Beth, me, everybody. It's the surgeons who are in control of this. That's a good thing.
One other question that you just made me think of with your anesthesia, pelvic pain complication. What about the every once in a while it happens, no matter you do enough surgery, it happens where you have a long acting, unintentionally long acting block.
Yep.
What's the protocol there?
So we've not seen it in the spinal. We did have a case reportable event. In fact, I contacted some of Nick's colleagues at Mayo because they were the only ones that in the English language reported it, which was a contralateral, just happened. It's the only out of 8 years of doing same day discharge in ASCs, the only hospital transfer I've ever had, believe it or not. Now we've been conservative. I haven't been overly not as aggressive. I have been post-COVID. She had a contralateral foot drop on a primary knee on the other side. And it's case reportable. It comes from inflammation of the lumbar plexus. And it was somewhat, and it can be asymmetric. That patient I transferred to the hospital because the one thing we did not want to miss, she got a thoracic and lumbar spine MRI.
Yeah.
So we did not want to miss some sort of event from either the spinal or bleeding, some rare event because she had motor out. Now, if she had symmetric dense block, different story, right? Something, or just everything was dense and slow coming and her, but you have to be prepared. If you think there is anything related to that cord or they have a spinal, that could be, you have to get them.
Right. What if it's not, you're not worried about the cord, let's say just a long acting IPAC, which is that knocked out your, when
You're ready to pay overtime. Got ready to pay overtime to the nurses to stay. And that goes.
So you will wait for their motor to come back before you send them home. Yeah.
Yep. And now the exception to that, this is why we do them, are adductor canal blocks. Those, we have knee immobilizers in the ASC, because as we reported in JBJS a couple of years ago, there is an 8% chance of adductor canal blocks, even though they're better than femoral nerve blocks, of getting the motor branch. So you really have to test those people's quads and the fact they're stable before they leave the ASC after knee surgery. But once we looked at that, and if you look in that paper, it's dose dependent and whether people are obese or skinny. Obese people are protective because they've got so much tissue to absorb they've got more tissue to absorb the anesthetic. Skinny people are at risk, stays in the canal and shoots up, gets the proximal branch. You got to have a knee immobilizer. Yeah. We send those patients home with a knee immobilizer, call them the next morning, make sure they got strength, and then they can take it off. Great points, great questions. All good questions. All right, let's see the results of this poll. Yeah, hospitals transfer safety net. And look, 63% of people are still not doing them in the ASC. So they're still, it's interesting. You got people in this country that are doing a lot. And then you have the majority, I would say, that are sort of in probably where you all are, which is like they're doing some, but it's not a full blown, you got, probably Keith on one extreme won't do any more in the hospital, and then other people fully in the hospital, and everybody's sort of probably in the middle. A skilled nursing facility, that worries me a little bit. I feel bad for people to put that. That would not be my safety net option, if at all possible. So, all right, let's pull up that next article. This was an interesting article, came from your institution, Beth, which is about things related to failing to discharge. The best way is prevention is worth a pound of cure in this case, right? And I think what we've all realized right now, this was, I think Mike Aft was part of this, and, Jose Rodriguez, and they found, to your point, to all of your points, actually, social determinants was a big reason. Later cases in the day, those sort of things really were like primary drivers in this. What we've come up with as the number one issue really now, but we're getting much, much better at it, is urinary retention. That has been the number one. I see you nodding. All three nodding your head. Does anyone disagree that urinary retention is probably one of the prime thing that delays?
Yeah,
Anyone?
it's the biggest one, and it's the most frustrating one because we can do all this optimization, we can do social planning, do all this stuff.
Predict it.
The patient can be super motivated, and it just isn't happening. And so that's why I'm nodding, because I just had one the other day, and it's just frustrating.
It is, and you can't predict it very well either. And the other thing is, the ACUS award paper a couple of years ago was an RCT, randomized controlled trial on using, the preoperative medication for it, that, some people were using, and it didn't work. It didn't show any difference. So it's really hard. We try and risk stratify it best we can, but at the end of the day, what we've realized, because we have 2 ASCs that we work in now, one really rapidly discharges them. Like they treat them like they're a carpal tunnel almost. Like they're up. We look out the window. I'm not even done with my second case. I look out and the therapist is like working with them. They have probably a little bit less of a rate of urinary retention. I do think getting people up quickly is helpful. I really do think that, especially males, the more they're upright and walking around, I don't know, I think it's the better, but anyway, it's going to be a challenge for us. This will be the last thing that we all probably conquer, is this urinary retention. All right, let's go to the next last poll question. If you performed an outpatient total knee at the ASC and sent the patient home, let's talk about pain management. Now, quickly, we'll go Lenny first. Give us the basics of your total knee perioperative care for same-day discharge.
All right. So quickly, we've got a pre-op cocktail, acetaminophen, Celebrex, Lyrica, right before surgery. Intra-op, light general, low dose intrathecal spinal, fentanyl with bupi normally, adductor canal block, and a periarticular injection for everybody. And then Toradol intraoperatively, 15 milligrams, not 30, and potentially risk stratified IV corticosteroid that we're starting now, and then post-op regular multimodal regimen for post-op pain.
Love
I
it.
wanna hear
Hot
is-
topic. Hot topic. We're going to get to it. Love the core. We're going to talk about steroid here in a minute too.
Yeah.
Me and my anesthesiologist and our internal medicine have been debating it all week. All right, Nick, anything different than what Lenny just said?
Not really. I mean, I do a pre-op cocktail. I don't do Lyrica. It's just, there's actually a narcotic in and then we get Celebrex, some oxycodone prior to surgery. Intraoperatively, I'm doing adductor canal block, periarticular cocktail, and then spinal anesthetic for most patients, usually mepivacaine spinal. And then post-operatively, I mean, this is the same regimen, outpatient or inpatient
Yeah,
for me.
good point.
That's important
Good
thing. Inpatients don't need more pain. So same regimen either way. And then I'm a big believer in the non-narcotic medications. All my patients go home with 2 weeks of Celebrex if they don't have active contraindications to it. Scheduled Tylenol and then occasional narcotics. But I think that we've been able to cut those down dramatically.
Beth, anything different?
Yeah, pretty similar. I'm not giving the preoperative oral meds, although maybe I should start. I do a periarticular block, typically get spinal, mepivacaine is my preference, and IPAC. And then oxycodone or tramadol, according to their preference, what they can tolerate, plus meloxicam or Toradol, depending on their age, Tylenol. And then in the PACU alone, they can get breakthrough dilaudid pushes, but once they hit the floor, they can't get those anymore.
Great. Yeah, I think, we've arrived at a lot of consistency, right? And kudos to, really Nick, your Mayo Clinic colleagues have done a lot of work in that regard over the years. And everybody sort of arrived for knee replacement at this general preoperative loading, I think in general, perioperative control with a single shot spinal usually. The light general is an interesting concept because that term is interesting. It can be propofol, it can be, we try to avoid gas because of the nausea that it induces, but nonetheless, light general is something quick. They come out quick. And then the periarticular injection, that's pretty much mainstay. And now adductor canal block. Does everybody have their anesthesia give their adductor canal block? Anybody doing it themselves? I assume anesthesia.
Anesthesia.
Still.
Yeah, same as us. same as us. Okay, I want to dive into, and we're very similar. Nothing dramatically different around all that. I want to dive into this poll and then go to the article I picked because it brings up the issue of steroids, which is a hot topic right now that seems to be unchecked in our profession. All right. Of course, 50% of people would not perform outpatient. That's consistent. Yeah, knee injection. Boy, some people are just doing blocks, narcs, and non-narcs. Okay, it makes sense. Yeah, it's a combination really of all of them. Let's bring up that article, and let's talk about steroids because I think everybody's pretty uniform on, anti-inflammatories if they don't have any contraindications. We do Celebrex for a month on everybody, sometimes 2 if they're struggling at the end of that 4-week time period. We minimize narcotics like everybody does, but knees just need them for a period of time. But this was a recent AUKUS award winner, not this year's meeting, but last year's meeting, about giving a second dose. That's not whether to give it or not. Now, I didn't bring I really wanted to focus on one article. I want to balance this with a paper that just came out from Vanderbilt, also under arthroplasty, that showed increase perioperative blood glucose levels, even in non-diabetics, because many of them are pre, but non-diabetics, and a trend towards a higher infection rate, giving perioperative steroids, which is why our internal medicine physician, as Lenny knows, because we're the same, will not let our anesthesiologists give this to diabetics or pre-diabetics, which is 70% of our patients. So quick thoughts on this, steroids, post-operative control. Let's start with you, Beth. Are they doing that at HSS? Do they monitor glucose after surgery?
I like it, but you're absolutely right. We have those limitations if they're diabetic or pre-diabetic, which is an overwhelming majority of my patient population.
Ours too.
and if your periarticular cocktail includes any DEX in that, then it will have to come out as well. So I've kind of gotten to the point where my patients are so old and sick that I'll use basically just bupivacaine in my block because I was just having to take everything else out of it anyways.
We're similar. We do the same thing. I don't put any stuff in there because I just don't have to bother with how many people can't get it.
Yeah.
Nick, are you guys using steroids at Mayo?
Yeah, I wouldn't say across the board. We're getting ready to start in Charlie Hannon's study that's doing an RCT on dosing of steroids and pain and nausea postoperatively. I didn't mention this in my thing. Most patients get 10. I'm not doing a second dose, but most patients get 10 of DEX intraoperatively. The infection thing is an interesting one. My guess, once we figure that out, is if there is a sense, it's just these really poorly controlled diabetics that are getting big spikes around the time of surgery. Parvizi showed that really poor perioperative glucose control can increase your risk of infection and stuff. So that's my guess, is in the fragile diabetics that are really jumping super high, but that can be managed as well. So if you can treat blood glucose and you can keep it within a range, and if it's a patient that is jumping that high, they probably take insulin anyway, so they're probably managing their own glucose. But I give it almost everybody unless there's somebody that pushes back, but I haven't had that very frequently amongst our anesthesia team.
Well, it's an interesting point because if you read that article out of Vanderbilt, they actually had to use insulin pumps to help control the blood sugars because if you truly pay attention to them, they're not insignificant, even in patients who are not classified as diabetic. So we're going to have to wrestle with the question, is the side effect of the medication and the risk associated with it actually, when you're discharging the majority of patients going home a few hours after surgery, is it worth the risk of not knowing what's going on afterwards? Because I hope in your study, one of the things I didn't love about this study is it's only about pain and nausea. They didn't even, their intro paragraph, God love Rand. I mean, if he watches this, he'll probably be mad at me. But if I was a reviewer, I would say the same thing. The intro paragraph talked about the reason there's pushback is because of postoperative glucose. Guess what? They never mentioned the rest of the manuscript, including postoperative variables or anything. And it won an AUKUS award. Glucose. Didn't even measure it. Didn't even talk about it. I mean, how can you talk? I mean, really? Anyway. Okay. Lenny, thoughts around this? I mean, you take care of sick patients all the time.
Totally. And it's still a hot topic. I mean, the clinical research award paper from this AUKUS was out of Henry Ford looking at this topic, which is ASC patients going home the same day. Does oral corticosteroid decrease post-op pain? And they showed it did, but there were a number of limitations for the points you pointed out, which is it was only powered to really look at pain. And it was questionable if there was actually a meaningful difference in pain. The VAS score that they used was probably not really a minimally clinically relevant difference. So I don't know the answer clearly, but I don't know. I mean, I'm pretty biased too. Pete says that it increases glucose, and until there's better data to support that it's really going to drive down narcotic use, I don't know that we're adding a ton of anything but maybe some risk for these people.
Yeah, I know we need good studies. I hope that Charlie is looking at glucose and not just, I was looking at all of it, right? And now that we have these continuous glucose monitors, that's gonna be helpful, right? To be able to really understand it.
Yeah, absolutely. But I think
Okay.
it's something good to keep in your back pocket is, so if you're not liberally using it
Yeah.
and and your
I
input,
agree.
having nausea, pain issues, you're kind of getting
Yeah.
towards the rope and high dose narcotics, and you're not worried about their particular glucose or you're monitoring it. It is a good drug to have in your back pocket as well.
Oh,
for that.
yeah. I mean, about 4 months ago, I had horrible sciatica. Guess what I took? Medrol dose pack. Guess where I felt great for about 4 days? The Medrol dose pack. When it wore off, guess what I didn't get rid of? But when you're getting the doses of steroid, you're feeling really good. You're really good for sure. That was the last one, I believe. There's the post-operative x-rays. So this patient of mine, we did do an ASC. We did discharge him same day. To our point, everything was optimized. We have a very unique program where our perioperative medical specialist is trained in this, and we've worked for over a decade doing research on how to do it. So there's a bias there for sure. We did do, Beth, uncemented fixation, even in this older guy, but his bone was great. And older farmers around here, they have diabetes, heart disease, because they've eaten bacon and eggs their whole life, but their bone's really good. So he got a cementless knee, and go ahead and show the next one. There's patella. We didn't touch that, left that alone, and then go ahead and go to the next one. And here he is at 4 weeks post-op. Incision pretty well healed. And he was doing really well. And he hasn't, thank goodness he hasn't had any issues, but an entire program really designed around from start to finish following this patient. We use patient engagement. We didn't mention this. We use a patient engagement app where we're constantly dialoguing with the patient and their family, in addition to our nursing staff. And just for me, I have 2 nurses, so we have a lot of communication. So I think, a lot of you brought this point up, and I think a lot of the people taking our polls has some hesitation around same-day discharge for the right reasons, because you do have to have a whole program in place, and it takes resources. Otherwise, patients won't be safe. I'm going to go through each of you. Last, parting comments. Lenny, any parting comments on things we've discussed or further thoughts you have around this topic of technology and outpatient?
No, I think it'll be interesting when we get to the course, diving in a little bit into your post-op x-rays on a 74-year-old male with a cementless knee with no patella. I think Beth has probably some fun things to say from New York. That'll be really exciting. But no, I think when it comes to outpatient surgery, I'm excited that there's a trend towards improved patient safety. And really that's our goal, is to make these surgeries safer for everyone. And that's what we've learned by transitioning to the outpatient realm. I think that we're just being pushed to keep our patients safer around the perioperative period. So if you're going to adopt it, I think having a multidisciplinary approach, and there's so many thought leaders like yourself that have done this well now at multiple places, that you don't have to reinvent the wheel. So find somebody that knows how to do it already and have them help you. So those are my thoughts.
All good points. Nick?
Yeah, I would just second that, outpatient surgery is not necessarily an easier pathway from a workload standpoint. You need to put resources in. You can read the papers on, you can talk to people that have done it, but you're also going to have to make an investment in people that are going to help move things along and have a team-based approach. And then with going to an ASC, I used to have some ASC practice where I was previously at. You have to be able to deliver a consistent product to the patient, to the PACU. And so if you're going to be out there, before you start doing that or dabbling in other technologies and things, you want to be able to take care of your part intraoperatively so that the patients are coming out at very consistent pain levels. They're coming out ability to ambulate, consistent knee range of motion, things like that. So consistent products for the ASC and invest in time and the resources to make an outpatient practice.
Yep. Sage advice. Beth?
Yeah, Lenny, I don't know, man. There's a lot more cementless CR knees with unsurfaced patellas, even at HSS right now. The world is changing since you've been there. But yeah, I think this is a great example of just like what can be done, and I think that we're pushing the boundaries more and more, but still doing it in a safe way. There's only a finite amount of resources in the world. And we're spending a lot, I think, when we keep people 2-3 nights in the hospital that don't need to be there. And I think you guys really reiterated that many times today. And it's like, if we can produce a reliable, standardized product in this way that's safe, there's really no reason not to do it. We're just wasting money if we don't do it.
No, I think that's great advice from all three. So I want to take this time to thank all three of our faculty for a great webinar, a hot couple topics, technology, knee replacement, and outpatient same-day discharge. Again, thanks to our sponsors, the IOEN hip and knee technology and outpatient course to be held in Indianapolis, May 11th through the 13th at the JW Marriott. So love to see as many of you there. We will dive into these details in greater detail. And thanks again to the Ortho Bullet team for their guidance and for putting on this excellent webinar. Thanks and have a great night.